welcome to the Medical Fitness Podcast. My name is David Flench, and I am the president and CEO of the Medical Fitness Association. Today, we're digging further into a topic that comes up all the time in our industry, clinical integration. It's something a lot of organizations are talking about, but when you look closer, it can mean very different things depending on who you ask. In many cases, we're really seeing some strong programs being built alongside healthcare, and those programs are very important. But at the same time, it's not the same as being integrated into how care is actually delivered. I would say medical fitness isn't a program so much as it's a pathway. So today, we really want to unpack all of that. What does true clinical integration actually look like? Where is it working today? And what has to change for more organizations to move in that direction? So I'm here today with my two co-hosts, Jeff Young and Thomas Hammett. How are you guys doing today?
I'm doing well, thanks. I'm excited to get into this topic.
Yeah, same.
Well, let's dive right in. I think one of the big shifts I see happening is moving from just thinking about programs to thinking about this in a systems concept. And so for a long time, the focus was building programs and still is, I would say, whether it's for chronic disease, mental health, specific populations. But I would say healthcare doesn't operate only on programs. You have to have these structured referral pathways and defined roles, outcomes tracking. We recently had a conversations about how important outcomes are. So all of these things are critical within clinical integration. So I'll start with you guys to start this topic off. How do you see the gap between how fitness and programs are structured and how healthcare actually functions?
Yeah, so and I think, Jeff's lived a career of delivering something that has legitimate medical benefit to people and living with the frustration of not seeing, at times not seeing the referrals that he hoped he would, and at times having seen those. And his input, I'm excited to hear about this. My perspective has been kind of in the middle, right? As a both as a practicing physical therapist, someone who gets those medical referrals as part of what would be an established medical pathway. But then within clinics and what I now supervise is within a larger system. How do we get our fitness programs and what we would call our lifestyle medicine programs to be as integrated as possible into the medical systems in which they exist or outside of which they may exist, and get the due recognition and referrals that they deserve. And to your point, David, a lot of the time it is that the referral pathways are the most important thing. To have if you're on an Epic EMR or some other kind of electronic medical record, to have a simple referral tied to a diagnosis that sends patients directly to your door and gives you their phone number as someone who's been referred to you. Man, there isn't much better from a lead generation tool than having that kind of established pathway. What I'll say, and I think something we started to talk about before this call, I wouldn't necessarily say that programs are the bad guy here, or that it's integration versus programs, because I think that programs are an important ingredient in having a successful referral scheme. And we've learned this through having separate referrals to a program that we called Healthy Foundations, and one to the department that we call Lifestyle Medicine. And it wasn't even close that our more successful referral pathway was to the program, to Healthy Foundations. But having the pathways themselves was really important. We did get referrals to both. The benefit of a program is that people can understand structure. They understand what you're going to get out of whether it's a certain number of visits or a certain kind of education or a certain kind of outcomes that are tracked, um, and outcome that may be not necessarily promised, but expected from such a program, it's incredibly desirable to medical providers who otherwise don't have a tremendous amount of comfort selling this kind of service. So the more they can identify as to what they're selling, yeah, programs help, but integration is really important too. And if you just build programs and expect people to come, the whole like build it and they will come kind of mindset, I think that's a world that a lot of people in medical fitness live in frustration with. So that's my initial reaction to that. And I don't know, maybe I'll pass it off to Jeff to see if you have any other thoughts, Jeff.
Yeah, I first of all, I love what you said. Agree with you with what you said. Um, I could come at this from a bunch of different angles. I struggle a little bit with where to start. I guess where I'll start with is that I understand the importance of programs for the reasons you said, but I'm also very frustrated by it as well. I go back, I think across my career, I think about how my first job out of college was at Duke Medical Center. So that was program, that was medical weight loss. And so that's what brought people there. But from a programming standpoint,
Mm.
we followed ACSM and NSCA and, basic guidelines. So it didn't really, at least my memory of it is it didn't really affect how we programmed. It just was a thing that brought them in. And then I've been at UCLA Medical Center's Ganda Diabetes Institute and Beth Israel Medical Center's Friedman Diabetes Institute. So that those are programs, right? It's related to diabetes. But as far as the way we programmed, we didn't make it specific to that condition, with the exception of the obvious modifications that were needed. But we still followed the general guidelines from like set and rep schemes and and things like that. So on one hand, I do understand the need for programs uh, to draw people in, and so they understand where why they're going there or whatever the case may be. But on the other hand, I think that program specific approach can lead to underdosing and can lead to confusion. And how do I need to do something different for this person, when the truth is, and you both know what I'm all about, and what Andrew Mock and I are all about, that no, there's a framework that everybody can actually fit within. I'm actually getting ready to present tomorrow at Rutgers University on this. There's a framework that everybody can fit within, but then you modify based on the conditions they have within this framework. And so the framework is a very progressive framework that actually drives the adaptations you want because of volume and intensity and things like that. Not saying that, no, I need to do some design a program for a certain way because this person has diabetes, another way because this person is postmenopausal, with osteopenia or osteoporosis. So it's a weird thing from my end, because I've worked in these or in these atmospheres where it was program specific and I understood it, but it didn't affect the programming. And that's what drives me crazy.
Jeff, do you feel like when you have a program, it's easier to communicate that and start to get that in the mindset of the clinician and the referral source, or does that not even matter so much as compared to building the relationships and establishing credibility and trust with those
Yeah.
based on variety of factors? What do you
Thank you
think?
for asking. Yeah,
Yeah.
my experience is that it didn't really matter. The program is what brought them in, but what actually, at Duke, um, referrals were built into the model. Like, it was just built in. So they just referred, because it was part of the program. I remember talking to Jeff Duran about this, and that you need to create a culture and a system where you just build it in. And I've definitely been on both sides of the fence where at Westwood Physical Therapy, you heard me talk about this before in Los Angeles. They built it into the program, but you need the trust to go along with it, because they're not going to just refer if they don't trust you. So there needs to be that as well. And then that can open up a whole umbrella and can of worms. How do you build that trust? Well, first of all, there needs to be competency, and they need uh, to experience that you're competent. They not just that you have some letters after your name. They need to experience that you're competent, and then that can break up another can of worms. Well, then how do you have that happen? Well, be involved with in services, and and train them, and collaborate with them and don't operate in silos and things like that we could probably talk about forever. But yeah, I think that you need to kind of create a culture where referrals are built into the system, maybe draw people in via the programs, but that doesn't necessarily need to affect the programming. But then you got to also within that culture, you have to create that trust, and not operate in silos so that you are truly collaborating.
Yeah,
Yeah,
go ahead, Thomas.
I just want to say, Jeff's making a great point. And I think what I hear, what I when I hear Jeff's response about programs, the first thing that I'd say, I think programs work from a sales standpoint because people can see them and say, "That's for me." You know, like you can see something that aligns with a need that you have and say, "That's for me." And uh, a lot of the time people think about the problems they want to solve rather than the solution. So, joining a gym is the solution. The problem that they have is that they have some kind of diagnosis, or they want to look a certain way, or they want to feel a certain way, right? Or they're at a certain stage of their life, right? And there's psychology to aligning people with a program that meets those needs from a sales standpoint. What I love about what Jeff's saying, though, is that when it gets to the delivery of said program, if the identity of that program leads to gimmicky or suboptimal behavior, which does happen. There's a lot of gimmicky stuff out there in the fitness world. There's a lot of gimmicky stuff in any industry, right? But we know about the gimmicky stuff that exists in the fitness world, and uh, a lot of the time that's aligned with programs that overpromise things by doing flashy stuff. And PT is guilty of that in our own world too. So I think if I was going to legitimize the psychology of programs, it would be that it opens people's minds and aligns with their needs. But Jeff, you're spot on, man. Like if that identification of the program then leads you to behave in a way that is different for the wrong reasons, then yeah, I mean, that's a different problem.
You worded it so
Yeah,
much better than I did.
well,
Yeah.
and this kind of brings me back to I hear people asking all the time, how do we create and develop and implement medical fitness programs? We want to start doing these programs, and to me, it kind of a lot of what you just said is part of the answer. It's you can have a program that sells it to the public and gets it excited. I could remember programs that we ran at some of my facilities, one in particular where I would say it was very much dependent on one staff person within that program. And then that person left, and we weren't getting referrals into that program anymore because it was just built on that level. There was no, like you said, Thomas, and Jeff, you said too, at some of these facilities, you have an automatic referral pathway and it's built into the system. And that pathway, regardless of whether you call it a whatever program, if it's built in, it's going to continue to happen. It's going to be sustainable over time. And I think that's one of the things when people think about just building a program. And a lot of what you said goes into that. They might not have the right programs. They might not be tracking the right things and reporting them and having the communication loops. And there's a million things that we could probably identify. And part of this today is we can dive into some of that and how it's working. So that kind of but I think I would say if it depends on a program or a relationship, it can be fragile. And really, if it's built into these workflows, then you get scaling and you know eh, relationships certainly are part of it. They open the door. But I think if you have these structures in place, that's what keeps the doors open and keeps people coming. So, I think that kind of just leads right into where I wanted to go next with this, and it's really talking about the legitimacy of and the role of the care team. So, um, you know, being being part of the care team is important, and um, I kind of want to get into that now and really just explore what you see working well, and being visible in the process, being accountable within this process.
I'll chime in first, just real quick. I can tell you got a thought, Thomas, so I'll make this quick. I know that we had talked previously about are we viewed as part of the care team or still external to it? And my view on that is that there are pockets that exist where we might be viewed as part of the care team, but I think as a whole, we're still kind of external to it. When I say we, I'm talking about the fitness professionals, exercise professionals. I think as a whole, we're still external to it, but I think that that's what led to this movement going on currently mostly behind the scenes that I think a lot of people don't know about, and that's the professionalization of the fitness industry and this QHP movement, so that there's going to be standardization and qualified exercise professionals. Um, this assess, prescribe, refer movement that's going on, which we might talk about in a little bit more detail later on. So there's movements going on, but those movements are driven because, at least in my view, we are not really viewed as part of the care team. We are still external to it. And honestly, I think it's justified because I think that the fitness industry is low barrier to entry, and if I were a clinician, I would lack a lot of trust as well and see it as even though it should be part of the continuum of care, I would see it as the fitness industry as a whole as being something separate. But fortunately, there's pockets that there's exercise physiologists and kinesiologists and those who are competent that exist and then can be made part of the care team. So that's my view on it.
What do you think we have to do now to become more part of that, rather than just be, pockets of it and mostly on the side? What do you think has to be in place?
I definitely have a view, but I want to let Thomas chime in and then I'll piggyback off him.
So, I think if you asked, I talk to a lot of physicians and medical providers on a pretty regular basis, the hospital contract that we have. So I have pretty regular meetings with people in the clinic network, primary care specialty physicians, because of the departments that I manage, cardiac and pulmonary rehab, and a lifestyle medicine department with physical therapy. So think about orthopedics and endocrinology and cardiology and pulmonology are all like giving me their honest views on referrals within our departments and asking the questions that whether or not they're giving me their honest views or telling me what their honest views are. And, uh, I think the first question is, do medical providers believe that physical activity is a problem that they should be charged to solve? Does someone's fitness behavior live within uh, their sandbox is something that they should address or not? And, I think the beauty of the lifestyle medicine movement, Jeff's seen over the years, and David, I'm sure you have too, the movement of physicians to be aligned with the idea of lifestyle medicine as being within their sandbox, not just prescribing medication, not just dealing with the most acute issues, but supporting people with, what leads to chronic medical issues. Is within their role. Um, but they'll only go so far with that and may not make recommendations based off of really simple things. Does it cost any money to my patients? And if so, I don't know if I'm willing to recommend that, though they're willing to do the same thing with medication. Um, an understanding of the value of exercise. While we know physicians are incredibly intelligent people, they often do not get education about the benefits of exercise unless they exercise themselves or went to a unique university and were listening particularly well during that one lecture on how exercise affects every system of the body. And when a complex patient presents in front of them, they have a choice of the number of things that they're going to address with that person in that moment. And oftentimes they do not make the choice to get into the weeds about exercise, despite the fact of what the three of us know, that regardless of any of those specialties that I mentioned before, if they started being regularly physically active and performing a resistance training program on some regularity, that many of their medical conditions could be managed better, that the medication that they use could be reduced. And physicians have a choice every day to show up to work and decide, is that part of my role or not? And a lot of the time, their behavior is predicated on what they know, what they believe, and how easy it is for them to refer to something within their world. And we have we have the ability to impact a lot of this stuff by the relationships that we build, but then also where we exist and how connected we are. Uh, and the easiest one that we can impact is how connected we are in the relationships that we have with those people. It is work, but it's something that you can actually see pay off. So I guess that's probably a good place for me to pause and see your reaction.
And I'll come in and say that, since I'm on the fitness professional side of the fence, um, and I think what I'm getting ready to say is probably a little bit idealistic, but it's because the system is so broken. But I come at this, at least in part, from a competency standpoint. And how are we going to fix this? Well, the standards needs to be higher. The competency needs to be higher. And unfortunately, the fitness field is, as I mentioned earlier, it's low barriers to entry. Well, if the person is apparently healthy, and you're at least competent enough to train someone who's apparently healthy, then that's okay. But once you start adding in medical conditions into the situation, now we're talking about layers, potential layers here. Like, for example, if it's cardiac rehab or something like that, then you need to have the degree and the higher certifications and the competency to go along with it, the experience and stuff like that. If we drop down a layer maybe and say it's controlled conditions that aren't uh, don't fall into that category where you need medical oversight or whatever, you still need higher standards and competency, but maybe not quite as high as the clinical exercise physiologist or something like that. But I think that the competency needs to be higher, and then to me that means you got to bring vetting into the equation, which is just not happening, at least not from what I see. And so we're not truly vetting the competency. We're going off credentials, which is at least a part of the equation, but we need to vet the competency. Because again, if I were a clinician, I'm just speaking from again, my experience and all that stuff. But if I were a clinician, the letters aren't enough. I'd want to know you're going to be safe with my patient that I'm referring, and so that again starts with it just keeps looping around in my mind that uh, goes right back to the whole trust thing. Let me give a real world experience to wrap this up. When I first started at Mount Sinai in 2006, and I'm 10 years into my career, and I'm the founding fitness coordinator and a faculty practice provider, but I didn't have a clue how to design programs for people with musculoskeletal conditions and with most chronic disease, because all we learned in exercise science for the most part was cardiac rehab and things related to the cardiovascular system. So I didn't have a clue. And very quickly, I could see they didn't just trust me. When I say they, I'm talking about the family medicine physicians, internal medicine, the one who were referring to me, the physiatrist, the physical therapist, and they were justified because I had the letters, I had the degree, but I didn't have the competency. And so what they did, fortunately, rather than fire me, thank God, they referred the ones who were, in order to develop trust, they referred the ones who were less complicated. So just general knee pain, general low back pain, controlled hypertension, controlled diabetes, while they're simultaneously taking me under their wing and teaching me. And also teaching me from the orthopedic standpoint and the language of pain management and therapeutic exercise, and making sure that I'm understand safety from their standpoint, from a medical standpoint. So I was just very fortunate that they took me under their wing and taught me how from their perspective what it actually means to be safe and what it means to be a trustworthy referral source. And so there's my real world experience, and I just think that that needs to be scaled in a perfect, an idealistic, perfect world. We need to scale that so that we start making sure that exercise professionals do speak the language of pain management, therapeutic exercise, modifications with people across the spectrum of whether it's cardiovascular disease, pulmonary disease, metabolic disease, neurological disease, etc., and make sure that they're being vetted and they understand those skills. And I'll say one last thing, and then there's also soft skills. So I look at hard skills as knowing those things, and then knowing your sets and your reps and your rest periods and your order of exercise and all that stuff. That's the programming, that's the hard skills. But you also need soft skills, active listening, empathy, things like that. Allowing some autonomy so that as an exercise professional, you're not a dictator, and that you're working, you're actually working and collaborating with your client and allowing them to have input. All those things matter, and all those things create a system that will then help lead to, oh, okay, this person is trustworthy. But it takes a vetting process, and I just feel like that's a big missing piece in our medical fitness industry. People are just going off, oh, I have 5 years of experience and these letters after my name, I'm good enough. Maybe, maybe not. Let's actually see.
Today's Medical Fitness Podcast is brought to you in part by the Medical Fitness Association. As you're hearing in today's conversation, clinical integration is about more than just having programs in place. It really comes down to structure and how those programs connect into the broader care model. That's where the Medical Fitness Association's Standards and Guidelines publication and the MFA's facility certification come in. They provide a clear framework to help organizations move from standalone programs to true pathways that support healthcare integration. To learn more about how MFA can support your organization, visit medicalfitness.org. That's medicalfitness.org.
Go ahead, Thomas.
I just have one thought to that, Jeff, because you laid out a really good idealistic framework, and I agree with you. What I would say, the real situation is that earns credibility with healthcare partners. In my experience, it's really two things. Does the patient come back and say, that program changed my life? The second thing would be the patient comes back and says, I had a meaningful change in this health metric. You referred me to this and my blood pressure is better. You referred me to this and I'm taking less medication. Those two things, like if a doctor gets that feedback, the rest of the stuff, again, Jeff, you're right. Your ingredients are probably what leads to that kind of stuff. But if it's a good service and it works, that's what physicians care about, right?
Thomas, you're totally right. I think it's gold if a patient goes back to their physician and says, thank you for referring me to that, and look, it's helped me so many ways. I think the thing that we can do to push that along is to provide those outcomes, to not only trying to push them to the physicians, but equip the person you're working with to really understand what their outcomes have been, to relay that, because I agree that type of feedback is just that physician's going to feel like the champion of the world, that they did that, and they're going to want to keep doing that for all their patients. So I completely agree on that. I'd also say, you guys made a ton of other good points. One is that 25 years or so ago, this we've come a long way. Like the physicians knowing more now than they ever have in terms of lifestyle medicine and other things within that model. But not only that, I think there's so many more resources for fitness professionals, and there's awareness of needing additional training. Maybe not as much as we need to. We still have a little ways to go, but there are now resources that if you are dealing with complex patient referrals, that's out there. And in the medical fitness world, a true medical fitness center, you know, should have. And a lot of times, the facilities that I ran, we had not only bachelor level exercise science, kinesiology, etc., prepared staff, but we had masters sometimes PhD, which doesn't, like, to Jeff's point, doesn't automatically put you in the right spot to deal with this. It's other advanced training and experience and learning under others. That's why I love the comprehensive medical fitness model, where you have other disciplines within the same building, where you can have in services and trainings and just conversations about specific cases and all of these sorts of things. So I think I would say we've come a long way. We still have a ways to go to spread this out, but those are some of the important things. I mean, certainly building trust on competency of the staff is one of the critical points that we can make about this. I think the other thing that I would bring up is that having these systems for outcome reporting in place. A lot of places don't do that. Some medical fitness centers struggle to do that. Maybe they're doing it manually, and where does that go? Maybe they're not even really doing that much of it. It was built into the program initially. You've drifted a little bit, and now you're only doing pieces of it. Or maybe they're not. They're doing all of this great stuff, and they're collecting it in a way digitally, maybe that it can be done, but then it breaks down somewhere in the communication loop, and it's not well integrated with an EMR or some other way to get back to the clinician. So I think the systems and being able to communicate well is another area where we have there's pockets, like was said before, that are doing it well. I've talked to several that have great examples within their facilities of doing this. But that it takes time to develop these things. And so I think we've made good progress. I think there's still a long way to go.
I want to add to that real quick. So during my 10 years at Mount Sinai, embarrassingly, we were not good at uh tracking and measuring and reporting outcomes and stuff like that. And Mount Sinai shut down. And there's many reasons why, or this particular facility shut down. And I know that there's many reasons why it shut down, but I strongly feel that you're talking about right now is one of the reasons. Because if we had done a better job and referrals were coming in more, then we would have made more money, and we might have stayed afloat for longer or completely stayed afloat. And I also think about how we regularly had in services, so we had monthly in services, but we never used those. They were always just educational, and they were usually sports medicine based. We never actually used them to report on, hey, here are the good things happening with our programs. And we also always had monthly faculty staff meetings. And so since this was an integrated medicine, we had family medicine, internal, cardiology, physiatry, physical therapy, etc. 33 healthcare providers, nurses. So it was across a wide spectrum of care, but we never reported, hey, here's what's going on with medical fitness. Here are all the good things happening. Here's some case studies to get the excitement going. And so what you were talking about just made me think back in time and be like, yeah, if we had done those things to generate excitement via the outcomes and some case studies to go along with it, and not always just have in services for an educational purpose on here's how you rehab the knee with this particular condition or something like that, but also inserted every once in a while, hey, here's what's going on with the medical fitness and the outcomes and the programming they're doing there. Then the visibility would have been there, the discussions, the excitement, and I think we would have done a lot better.
Thomas, I'm curious because I know you work with your own health system, and then you have other groups that you've been working with, and health systems that are coming to you. And when if they were to come to you and say, we want to integrate a medical fitness model into our overall care model, what would be the first thing that you would want to look at to see if they're actually ready for that?
Yeah, I'm guessing that this is in this theoretical example, there's already some kind of fitness, or like where they're not starting from scratch, right? There's
Yeah, in a case where you actually have a medical fitness program or facility, or whatnot, but they want to integrate it into their care pathways and their whole
Mm.
model. Where would you think they would need to? I mean, because that's after getting a program started, that's, I think, one of the keys for these facilities to be able to figure out where within the health system it makes sense to start putting their effort into.
Yeah, I mean, I think the first thing that I would recommend is look internally first at your process and what you are offering. Is it simple enough that someone outside of your walls could understand it and sell it? And that level of competency where someone else could sell it without knowing much about it, it has to be very simple. Again, why I go back to why programs at a base level are important. Because when you're expecting someone with a couple degrees of separation from your department to be the advocate for your program or for your service, they need to be able to, at some level, instill confidence in themselves and the patient that they're talking to, that this is going to be something that's for them. Uh, so look internally. Do you offer something that is meeting the needs of your medical referral base? And if not, that's where I would start. And what Jeff was talking about tracking outcomes, man, it's not like you just make the decision to do it and start doing it tomorrow. This stuff's hard. We've spent the better part of the last 10 years getting good at building outcomes data collection into a process that feels both comfortable and meaningful to a patient, where they're not being poked and prodded and feeling like data collection is the source of this thing, like they're just a number. But that also makes it possible for you to say, on a semi-regular basis, we looked at these things and we got better, and it mattered to them and it matters to us, and it should matter to you too, referral person. So if those things don't exist, you're going to have a awfully hard time selling what you have to people beyond your walls. Then I would say, if you have those identities and uh, an ability to collect and report on the things that make people healthier, or that show that they're getting healthier by participation, yeah, it's time to start sharing that outside of your department and telling people what those things are and how to refer to them. And a lot of the times, if you're within a health system, that's easy. You get referrals built, and that's no problem. Even if you're outside of a health system, and when I started at my role at Pinnacle, we were a private practice physical therapy group. So we were our physical therapy practice was getting referrals from several local medical systems. Often there are several that refer to to outpatient groups, not just one local medical system. And our responsibility within the clinic was to manage up essentially the fitness program. Help people understand that the physical therapy plan of care does not stop after 6 weeks because we magically fixed you, right? So if you're outside of the walls, find a way either to tie yourself to a credible medical source that understands your value, or find a way in. There's ways in. There are provider champions that will speak to your value, that get it, that others will not get initially. But again, if you show the value of what you do, other providers will start referring. So I think there's different answers based on whether you're embedded within a medical organization or you're not. I think there's a number outside of medical organizations that have been really successful, and Jeff's been one of those. So
Yeah, I think one of your points, I just kind of like to go on briefly here. Physical therapy has done, as long as I can remember, has been embedded in the pathways, and providers know what they're referring into. So your whole point, and same thing with like cardiac rehab. That's been, what you're referring into, and I think, and actually, when those types of services are, you know, together in the same facility with a medical fitness center, um, they often know really well, okay, when they're done with physical therapy, what can happen next. that's known. Sometimes it's the 2 layers above or 3 layers above that it is harder to know. But now having the whole lifestyle medicine specialty, I think that's going to improve things quite a bit in terms of reducing those layers. But I do think oftentimes in my facilities, physical therapy was the best source of referrals, because once somebody got done with their reimbursable services, they still needed more, and so it wasn't just always go home and do your exercises. No, it was we have a step down program that we're going to hand you off, and you're going to continue doing some of the things, and we'll talk to the staff and kind of coordinate that between you. So I think that's kind of an important point within what you were saying. I think you do have to establish some of these things, but there are certain disciplines that should and do have better knowledge. So starting with them oftentimes is a really good way to start. Well, and maybe this is a good point to kind of wrap things in a bow. I think the big point that I would make from this conversation is that clinical integration doesn't just happen because we have good programs or great relationships. I think it happens when there's real structure, clear pathways, and defined roles, consistent communication, outcomes back into the overall process for clinicians. And I think this is where things are heading. We're getting better at this, but so opportunity definitely is there, but I think the organizations that are moving forward in the ways that we've just talked about are going to be ones who are building something intentional and have a pathway that they are developing, and it comes together that way.
And I'll add and say I couldn't agree more. And I love the fact that you said building something intentional, because that's exactly right. What I think about is an ecosystem, that the system itself is broken. Medicine, there's so much about medicine that's broken. You name the field, and there's so much about it that's broken. So the giant ecosystem is broken, and there's so many problems systemically from the top down, from the bottom up, etc. But you can still create your own ecosystem within that, and it starts with intent. And I actually think it starts with the hiring process. And I know that when you're trying to build something, maybe you don't have the luxury of trying to weed through a zillion people that you're interviewing and all that stuff and find every single person is perfect. It's too idealistic. But I still think that you need to know what your intent is, know what your vision and your purpose is. Make sure that you're hiring within that, and that's part of the interview process. And then the interview process is part of the competency process as well. And honestly, I think it's both sides of the fence. I think it's not just with fitness professionals, but also on the clinical side of the fence as well, which could open up a whole can of worms. But I really think that it's intent, it's culture, and then once you have the staff that you want, let's start creating the systems, the programming, the programs, the systems, the making sure the outcomes. The what you're going to track, what you're going to measure, the outcomes, the impact you want to have, and then make sure without a doubt that you don't operate in silos, that you keep working together, and via in services, via the exercise professionals training the clinicians on occasion, just so you can stay connected and have conversations in a little bit more of an informal attitude atmosphere and things like that. But I love the fact that you said intent, because those were all the things that kind of went through my mind.
I I think, I'm always tempted at the end to speak to this theoretical person out there that's like struggling right now. I don't know what that is. There's some psychology to that for me, probably. I think the perspective within medicine, if you're on the outside of medicine wondering how to seize the opportunity that is that 70% of people in this country have health issues that they need some form of support with, uh, and that what you do literally could help them with that situation. Um, and you're wondering how to break in, some of this is systemic in the fact that hospital organizations need to change. And that's what Jeff's talking about. When we talk about a broken system, it's that healthcare is sick care, and health promotion activities like exercise and nutrition traditionally are not viewed as being part of a long-term service that hospitals and medical systems provide, because it's not something you need when you're sick. That's what you need when you're healthy, quote unquote healthy, right? Not an acute medical need. The problem for health systems, if they stay in that paradigm, is that they'll continue to not adequately serve people in those situations. And healthcare will change. It will. And if you're out there and you're frustrated and wondering when you're going to finally get your foot in the door with healthcare organizations, my answer would be it's going to be soon, because healthcare organizations cannot stay in the same paradigm that they've been in for as long as I can remember in my lifetime, and it will change. So if you're out there doing good work and wondering when the heck it is you're going to break through and find the provider that understands you, the answer is probably sooner than you think. And keep doing good work, learn how to care for people, and I'll get off my soapbox on the, speaking of the struggling person, but I think it's important perspective, because doors that have felt closed for a long time will start to feel open, because the health situation does not give any other opportunity than what that has to be.
Thomas, I share that optimism. There's signs of that continuing to happen. A lot of signs from a variety of health systems, government, etc. It's happening right now. So I share that optimism, and I think we all share the belief that we need to close this gap between healthcare and medicine, rehab, fitness world. That gap needs to shrink, and that's kind of the basis of all of this. And so this clinical integration topic, I think, is just really important. So I do hope that listeners out there are hearing a lot of the points that are being made, and can look to improve on that. I think one of the best ways is to just talk to as many people out there who are doing things that you can look at and say, okay, what can we do better? So I think that's my closing thought, and I really appreciate the conversation today, guys. It's an important one, and glad to hear your perspectives.
Yeah, I echo that. I feel the exact same way. I love the topic.
All right. Well, thanks, guys, and I look forward.
Guys.
Go ahead, Tom.
Yeah, I thought it was just okay. We did just okay.
Yeah.
I'm kidding. It was great. It was great chatting with you. Sorry to interrupt you, David.
No. Well, I look forward to next time, and maybe we can even rise to Thomas's expectations.
That's right.
All right.
This episode of the Medical Fitness Podcast is brought to you by the Medicine, Rehab, and Fitness Institute. The MRFI has been co-founded by medical, rehab, and fitness practitioners who see the medical necessity in getting people to be more active and fit. There is a sleeping giant of opportunity to building a more active population, an opportunity which lies in a more effective medical referral pathway to exercise programs and professionals equipped to serve that pathway. To learn more about our services and how we're working to make this a reality, visit mrfinstitute.org. That's mrfinstitute.org.